So I'm happy to moderate this first session, which will be on current challenges to the delivery of affordable cancer care. And the bios of our speakers are in your brief handout that you had, so I'm not going to go into lengthy introductions, but I just want to welcome Scott Ramsey, who I mentioned earlier, chaired the value workshop, and we thought that it would be very opportune to have him speak and reflect upon what may have changed in the 3 years since then. So I'd like to welcome Dr. Ramsey, who's from the Fred Hutchinson Cancer Research Center. And he's going to be speaking on how should we define value in cancer care. Thanks.
Thanks, Patty, and thanks to everyone for coming today and joining us in what I think is going to be a really, really exciting workshop. So my task was a little bit to reflect on this workshop which we held in 2009, which I thought was a really well articulated by our planning committee vision of defining this problem that most of us know, but it has been hard to articulate in the past, which is that a lot of what we do in cancer is very expensive and actually offers very little for patients. And in some cases may not actually hurt patients. And with that in mind, the idea of the workshop was to identify that as a problem and then to come up with solutions, ideas, to address the problem of poor value cancer care. But before I get into some of the recommendations, and I'm going to review a little bit of the highlights of that workshop, I just wanted to step back for a minute and kind of give us a 30,000-foot or maybe even a 50,000-foot view of where we're at in terms of health and health spending. So this is a selected group of countries looking at the expenditure that they have as a proportion of their GDP over the last 15 years and their life expectancy gains over that time period. And what you can see is some really remarkable changes in terms of increases in life expectancy. Look at China, Brazil, look at Australia, a well-developed country, and Sweden, in terms of the number of years that their citizens are expected to increase in terms of their longevity, just over about 15 years. Now, all of these countries are spending more of their GDP on healthcare than they did back in 1995, but they're also getting quite a bit more. So spending more is okay as long as you're getting more. Now, where's the U.S. in this sort of picture? Well, we're out here. We're spending, historically and through today, about twice as much as any other major developed country in terms of our spend on healthcare. And as I said, spending is fine as long as you're getting good value for that. But when you look at where our life expectancy is, it's not looking so good. Yes, we're doing better than some developing nations, but we're worse than many developed nations, even today, with a close to 18% GDP expenditure. So in terms of this value issue, the U.S. is really lagging. And of course, we've heard a little bit about this, and I just wanted to make it a little more concrete. You know, that problem is continuing. Historically, we've spent, our healthcare spend has been about 2.5% higher than our GDP growth. So rate of cancer, or rate of cost of all healthcare is increasing. And you can see this is just spending for publicly funded healthcare, Medicare and Medicaid. And if we continue on that 2.5% over GDP trend, we'll end up with spending about 15% of our GDP just for two public programs, Medicare and Medicaid. If we get down lower to 1%, it'll be better. But I thought, you know, you see a lot of these trend lines, and I thought it might be interesting to sort of put it in more personal terms. So this is tax rate implications projected by the Congressional Budget Office a few years ago, looking at the implications of this increased spend. So let's say that somehow we can change our rate of change of healthcare spending from 2.5% down to 1% growth over GDP. If that's true, by 2015, we'll have reduced our overall GDP in the economy somewhere between 3 and 16%. And for those of us who are in the highest tax bracket, I guess that excludes presidential candidates, but for those of us who are in the highest tax bracket, 35%, will have our marginal tax rate go up to 60%. If we stay on our current trend of 2.5% over GDP, we're going to see substantial reductions. CBO couldn't even calculate the actual because it's such a substantial amount. But the highest taxpayers, those in the highest tax brackets, their marginal tax rate would go from 35 to 92%, and that's just to fund health care. So that's not politically acceptable, right? That's not going to happen. So we really don't have a choice in terms of reducing the amount of money we spend on health care and improving the value of that care. And Victor Fuchs, who's a health economist that I admire, said it well in a New York Times article. He said, if we solve our health care spending problems, most of our fiscal problems will go away. But if we don't, then almost anything we do will not solve our fiscal problems. So we can eliminate all the other programs for the poor and cut our military, and it's still not going to solve this problem because of this march of healthcare costs. So we have to face this problem. We can't run away from it. We heard a little bit about the landscape of healthcare or of cancer in the United States, and it's true that the landscape is changing. We're going to see by 2030 about a 50% increase in the number of cancers, in part due to population growth and in part due to aging of the population. The risk factor profiles and the cancers that stem from those risk factors are changing. We're seeing more cancers, and we're going to be seeing more cancers linked to changes in diet, physical activity, and obesity. And fewer cancers, fortunately, due to smoking, because smoking rates have declined over the last 30 years. But cancer is also turning into a chronic disease, and that longer survival is good, but it does mean that that's going to influence the cost of care over an individual's lifetime, which is increasing. And these are some of the challenges that we recognized at that first IOM conference on value in cancer care. One is the incentive structure, which was mentioned by Dr. Feinberg, that it doesn't encourage value-based care. It encourages substituting less expensive treatments and treatment regimens for more expensive treatments, more aggressive use of diagnostic procedures, of treatment and treatment combinations, and surveillance procedures after the cancer has been treated into remission. And because of this, and because of the fact that people are living longer, the survival gains are being magnified by the fact that the people who have cancer are surviving longer with their disease. So that test and treat imperative is really cascading through the survivorship period to push up the entire lifetime cost of people with cancer. I don't know if Tom Smith's here today, but okay, good, he's here. So I picked out a few highlights from the workshop just to sort of let you know what some of the thinking was back then, and I think we're going to come back and revisit some of these issues during the workshop. So he highlighted several issues that reduce the likelihood that high-value care will be provided. One is on the part of patients, which they have unrealistic or poorly informed demands for benefit. They expect to be cured when in fact cure is often not possible. Oncologists and oncology professionals in general have high income expectations when they go into the field, and that creates a perceived need to meet those income expectations through a fee-for-service mechanism. There's poor reimbursement for what most oncologists believe is a very critical component to bending the cost curve and to making expectations on the behalf of patients more realistic, which is the cognitive care. On the other hand, there's very high reimbursements, as we heard, for things that are related to just giving more treatment, in particular chemotherapy. Oncologists are suffering from stress and burnout as a result of this. They're spending less time in the things that are rewarding to them personally and more time doing more, running on a treadmill, giving more and more procedures. And finally, there's highly variable quality of care, and those of you who study issues of variation and cost know what that means. And I actually wanted to highlight that with some data from our own area in Puget Sound. This is a study that was funded by stimulus money, looking at variation in imaging and other cancer spending in the Washington State SEER region. So this is a graph showing variation in expenditure for commercially insured patients. We linked all the major health plans in Washington State with our SEER cancer registry. And this is just focusing on local stage breast cancer patients under 65 with 0 or 1 comorbidity, looking at the expenditures, the reimbursements paid from the plans to the providers in the first year following diagnosis. And these were the highest volume clinics. And what you can see between the lowest quartile and the highest quartile is about a 5-fold difference in expenditure. Now this is just stage 1, hasn't spread to the lymph nodes, breast cancer, in people who don't have other major medical problems. And we see this huge difference. And yes, a lot of it is due to chemotherapy, hormone, radiation. But the biggest difference in the bars, unexplained. Unexplained. A lot of stuff that we haven't even defined is going on. So tremendous variation. Now at the workshop, we talked about proposed solutions to the problem, and I just wanted to kind of go through some highlights here. Lee Newcomer talked about maybe we should just capitate cancer care and decide what a fixed amount would take based perhaps on guidelines, and say to oncologists, you're going to get this amount of money. If you spend wisely, you might make a good rate of return, but if you do a lot of extra stuff, it'll have to come out of your pocket. Mike Chernow talked about value-based insurance designs. In other words, designs where co-pays were set based on the value of the overall package of treatment, with the idea that it would encourage patients to use higher value insurance or higher value treatments because it would lower their out-of-pocket costs and discourage lower value. Jeff Lerner and Peter Bach talked about the idea that perhaps we could try cost-effectiveness thresholds. We have a whole literature of cost-effectiveness evaluation. Much of it's done in cancer, looking at the value of various treatments we do, and we could set a national threshold and say we will only cover things that fall below that, were more cost-effective than that threshold. Tony Bach talked about this issue of uninformed patients and identifying tools and implementing those tools to improve the doctor-patient communication pathway so that patients had more realistic expectations about what they could expect from their treatments, both in terms of the benefits and also the risks and impact on their quality of life. Hetty Ganz talked about improving incentives to switch patients who are at the point where additional treatment would be futile to move them into palliative care, and the potential savings and also quality of life improvements that we could see from shifting patients at the end of their cancer time, where they're in metastatic situations to palliative care. And Tom Smith talked about quality of care initiatives and incentives, the incentives that could be tied to those initiatives, where if physicians did what's recognized as high quality, they would actually get better reimbursement. And again, on that last point, I just show some data from Choosing Wisely. Now, many of you know about Choosing Wisely. It was an initiative started by the American Board of Internal Medicine, and there was a partnership with ASCO to focus on 5 areas, 5 expensive procedures or costly procedures where the evidence suggested that they didn't provide benefit. And the idea was to encourage physicians and patients to maybe think before they ordered those procedures. And in cancer, one of the 5, I'm just going to highlight one, which was the idea of using imaging in local stage breast cancer patients. And the Choose Wisely initiative here is don't perform PET, CT, or bone scans in the staging of early breast cancer in women who are at low risk for metastasis. And again, this is data from our own Puget Sound SEER registry, commercially insured patients, looking at PET, CT scans ordered during the diagnosis and staging period for local stage patients, again, no comorbidities, in those high volume clinics that saw the most breast cancer patients. So what do you see here? So this is the average number of scans received per patient. First of all, you see tremendous variation, ranging from very low to almost every patient with this local stage disease getting a PET CT scan. Now, what's the right number here? Well, if you go along with choosing wisely, it should be 0. But these are the high volume clinics, and you see this tremendous variation. So we've got a ways to go even on choosing wisely. So finally, I want to close with the definition that we came up with as a shared understanding of value in cancer care. And actually, Dr. Feinberg mentioned this, and I just want to repeat it, which is that it has to be from multiple perspectives. If we're going to talk about having value, we have to consider the patient's perspective of value, we have to consider the provider's perspective of value, and we have to consider the payer's perspective of value. And even though those are often conflicting perspectives, if we don't find a shared understanding of value that all of those different actors can agree on, we're going to have trouble moving ourselves towards higher value care. So I think that is a reasonable charge for us as a group as we move forward today. So it's going to require cultural transition, I think, to get us from where we are to where we need to be. It's not always easy. Cell phones were pretty easy. McDonald's was pretty easy, but other things are less easy. I think it's already been mentioned that this is going to be a very difficult, multifaceted problem, and the solutions are going to be multiple. But I'm confident that we have the will and we have the need to get there. Thank you.
Thank you, Dr. Veena Shankaran. Is Veena here? Thank you. Welcome. Veena is also from the Fred Hutchinson Cancer Research Center, and she's going to be talking about the economic burden for patients and their families.
Thank you all for coming. I'm very excited to be here, and I want to thank the Planning Committee for inviting me. I was charged with the task of discussing delivering affordable cancer care in the 21st century from the perspective of patients and their families. Forgive me, I have a little bit of a cold, so I apologize. So we've already heard that the cost of medical care and cancer care in particular continues to increase significantly. And what we're seeing is that patients are actually sharing a rising proportion of these treatment costs through rising health insurance premiums and deductibles, through high co-payments for treatments, in particular chemotherapies, oral chemotherapeutics, which oftentimes fall under outpatient prescription plan. And in some cases, high out-of-pocket spending for off-label diagnostics treatments. This figure illustrates the changes in health insurance premiums and workers' contributions to these premiums between 1999 and 2012 relative to changes in workers' earnings over the same time period. And as we can see here, workers' contributions to health insurance premiums have increased by 180%. Health insurance premiums have increased by 172% over this time period, whereas there's been a modest increase in workers' earnings over the same time period. In addition to the increased cost sharing that cancer patients are experiencing, cancer patients are also, in many respects, vulnerable financially. First of all, patients are generally sick. They're required to come in frequently for infusion visits. There are co-payments associated with these visits, costs associated with transportation to these visits, food, and various expenses related to coming into the clinic for treatment. Because of the nature of the disease and the nature of treatments, patients are often unable to maintain their employment and in turn unable to maintain their previous level of income. And then finally, because of the nature of this disease, it's a life-threatening disease, it's a scary disease, and patients may be compelled in many cases to accept new treatments or treatments recommended by their providers at any price. So given the increased cost sharing that cancer patients are experiencing, and given the unique sort of financial vulnerabilities that these patients have, we've seen reports emerging of many serious consequences of high out-of-pocket spending among cancer patients. We've seen reports of significant financial hardships, such as taking loans to pay for treatment, going into debt, depleting all assets to pay for cancer treatment, and personal bankruptcy. Some reports have emerged of noncompliance related to high out-of-pocket spending. Few reports on quality of life related to high out-of-pocket spending, but this is an area that requires some investigation. And then no evidence to suggest that patients who spend more to pay for their cancer treatment necessarily do better clinically. This was a recent study using data from the Medical Expenditure Panel Survey between 2001 to 2008. And as you can see here, the bar represented in blue is patients with cancer relative to other chronic conditions in yellow and no medical conditions in gray. Patients with cancer had, across all insurance plans, private, public, and uninsured, experienced a high total burden, which is defined as greater than 20% of income spent in health-related spending, relative to patients with other chronic conditions or no medical conditions. So a significant problem for patients with cancer. We recently conducted a population-based survey of patients undergoing adjuvant treatment for regional colon cancer, and found that among 555 patients that we surveyed, 284 respondents in the Sear-Puget Sound region, 38% of patients reported at least one treatment-related financial hardship, which we defined as being in debt, borrowing money from family and friends, selling their home, refinancing their home, or having a significant decline in income, greater than 20% decline in income. This is data from our group as well, which was a study of, again, the Sear-Puget Sound region between 2006 to 2010 of patients with cancer and age-matched and gender-matched controls, cross-linked to bankruptcy records from the state. We found that patients with cancer, younger patients as well as patients greater than 65, had a higher rate of bankruptcy compared with controls. So this is so the out-of-pocket burden of cancer care on patients and families is significant. And as we think about how to deliver affordable care in the 21st century, I think there are a couple concepts: delivering affordable care from a societal standpoint and delivering affordable care to individual patients, as Dr. Feinberg was mentioning. So I wanted to focus on affordable care from the individual patient and family standpoint, and how we can think about treatment value from the patient perspective. So I think one important thing that we can do is to include discussions about cost in the treatment decision-making process, develop systems to inform oncologists and patients about the total and out-of-pocket costs of recommended treatment regimens, and incorporate cost information into clinical practice guidelines. Perhaps the most important thing that we can do to help individual patients and their families is to not recommend treatments that are highly costly to individual patients that have no evidence of benefit. So let's talk first about clinical practice guidelines. This is just an example of first-line gastric cancer regimens that are accepted as equal options for first-line treatment, and these are from the National Comprehensive Cancer Network. All of these regimens are combination regimens of 3 drugs. I didn't spell out the exact regimens, but these are combinations of docetaxel, cisplatin, 5-FU, epirubicin, oxaliplatin, and capecitabine. And as we can see, median overall survival is relatively comparable between these various regimens. In fact, there's not been shown to be any statistically significant differences in survival across these regimens. But as you can see, and I used Medicare reimbursement here, but the reimbursement for these and the cost of these regimens are widely different, ranging from $840 for a 6-month course of ECF to nearly $60,000 for a 6-month course of EOX. So from a total cost standpoint, these regimens, choice of first-line regimens, have broadly different impacts on the overall cost of treatment. But from a patient standpoint, these regimens have different out-of-pocket cost implications as well. And I'll highlight these two regimens, ECX and EOX, which both contain X, which is capecitabine and oral chemotherapeutic. So as we think about choosing between guideline-endorsed treatment options from an individual patient out-of-pocket payment standpoint, not all treatment options have the same financial impact on patients. We talked about the example of capecitabine, which can range, the co-payments for this drug can range significantly from nothing to, in some cases, 30 to 40%, depending on the insurance plan. And the cost of treatment for 1 month of this drug on these regimens is roughly a couple of $1,000s. So that cost differential is significant. So toxicity, comorbidity, convenience, distance from cancer center, these are all things that we normally use to weigh our decisions of how we recommend regimens to patients. In addition, the cost to the patient could be one additional factor that we use in making decisions and choosing between multiple equally supported evidence-based treatment options. Moving on to high out-of-pocket spending at the end of life. We'll hear more about this later on in the conference, but we all know that we spend a lot of money on providing care at the end of life, and this is total cost. But looking at out-of-pocket costs, patients pay a lot for their care at the end of life. I'm just going to use the example of regorafenib, which is a drug that was just approved a couple of weeks ago by the FDA for advanced metastatic colorectal cancer. And this is an area where there was previously no available drugs. So these are patients who had progressed on all available agents for this disease. This drug was shown in a phase 3 randomized study to be associated with a statistically significant, though modest, median survival benefit of 6.4 months in the treatment arm versus 5 months in the placebo arm. And in thinking about a modest benefit like that, we have conversations with patients when we're making decisions about subsequent line treatment in metastatic disease. So again, these are patients who have seen a lot of treatment already and who've likely spent a lot on their care to this point. And factors that we often use in making decisions about whether or not to offer patients a drug like regorafenib would be their performance status. Are they well enough to tolerate the drug? What is the anticipated toxicity given all of the other treatments they had had previously? Are they motivated to pursue treatment? But what we often do not include in that conversation is what the out-of-pocket cost to the patient would be. I think this is of critical importance, discussing the cost up front prior to prescribing treatment. Is the estimated benefit of a drug like regorafenib, for example, worth the out-of-pocket expense to the patient? And when we're talking about end-of-life care and subsequent line treatment, discussion of out-of-pocket cost is perhaps as important as any of the other variables we take into consideration. There are many challenges, however, in discussing costs with patients. First, it's time-consuming and it's unfamiliar. Oftentimes, there's no ready information in the clinic to oncologists about how much patients are anticipated, their out-of-pocket payments would be anticipated to be. This is something that usually is triggered by the prescription itself, and then come to find out later, the oncologist and the patient, how much the out-of-pocket expense would be for the chemotherapy drug. A system is required to provide this information up front to patients and oncologists, and most instances, as I mentioned, this doesn't exist. And there's concern that including information about out-of-pocket costs in this discussion is inequitable. Many oncologists feel that we should just present the options based on efficacy and advise patients based on toxicity and other clinical factors rather than out-of-pocket expense issues. So in summary, cancer patients are experiencing high out-of-pocket treatment expenses. Treatment decisions have a direct and significant impact on patients' finances. Improving information exchange about out-of-pocket expenses in the treatment discussion could help to mitigate the financial burden of cancer treatment on patients and their families. We, as oncologists, play an important role in infrastructure for pharmacy billing specialists to provide real-time information about out-of-pocket costs is essential. To counsel patients about copay assistance and other financial resources is essential. And education to providers in conducting comprehensive discussions of risk and benefit of therapies, including financial risk, is essential. Thank you.
Thank you, and I'm really grateful for the speakers so far for keeping on time, so we're going to have a good discussion in a little bit. So our next speaker is Jeff Peppercorn from Duke University, and he's going to be talking about delivering affordable care in high-income countries. What are the known challenges?
Thank you. It's a pleasure to be here this morning. I would also like to thank the Planning Committee. I was asked to try to say cover many of the same issues addressed by Dr. Feinberg, but less eloquently. So I will try to do that. And also specifically asked to address some of the issues that came up in the Lancet Oncology Commission that I participated in. This was a collaborative effort to describe the challenges and ideally to propose solutions to the challenges of delivering affordable care in the high-income countries. Not that it's not important in all countries, but that maybe there's unique challenges that emerge when you don't have to consider some of the other challenges faced in medium and lower-income countries. This involved 37 policy experts, multidisciplinary group, including economists, physicians, patient advocates from the 10 countries you see represented here. And in summary, I don't think I need to hold out for the punchline. This is essentially what we found. As you've heard, the burden and cost of cancer care is growing. Some of the drivers of cost include the challenges and price of innovation, overutilization, lack of an adequate evidence base to guide practice, an inadequate regulatory system, both from the perspective of guiding practice and from science, from guiding innovation and lowering the costs, ideally, of innovation, and then an inadequate socio-political debate, both within this country and other countries. This is unsustainable for health systems, as you've already heard, and disparities in access are growing despite the amount of money we're throwing at the problem. So solutions include value-based reimbursement, education of patients and clinicians, regulatory reform, but I think we were, if I'm going to be critical of this effort, we were better at describing the problem than at proposing solutions, and I think that's a challenge. That's why we're all in this room, actually. But I think that if you were going to draw one overall conclusion from this, it would be that the era of high-cost interventions for marginal benefit clearly must end, particularly if we're going to have any resources left to provide high-value interventions to the broader population, to spend any money on further scientific discovery, not to mention the other important social goals. The big question is how. I'm not going to dwell on some of the figures I have because other people are addressing this in greater detail and more. Suffice it to say that there's multiple ways to measure total health care spending and spending within cancer. And I think we have to agree at some point on what is the figure we're most concerned with. Is it the total spending, or is it really the percent of GDP or the cost per case? And each of these have merits and challenges in their own respect. Another thing we can say is that we're spending about twice as much in the US as other high-income countries, whether you look at GDP or per capita spending for healthcare overall. We also know that healthcare overall is increasing greater than inflation, and that within this country it'll be consuming 20% of GDP within the next decade, unless something changes. Rising cancer care costs are a component of this. It's been relatively consistent within the US at about 5% of total costs, but there's a concern that it may be increasing in recent years, particularly with novel, targeted, and more expensive systemic therapies. You can see some of the breakdown, and ultimately, we need to start to address this by looking at the components, both within diseases, probably ultimately within stages of disease and even lines of therapy, and then the components in terms of drugs, surgery, hospital costs, radiation, not to mention genetic tests, imaging, et cetera. But overall, if you look at the trend, it's going up at a rate that's estimated to be a 600% increase, completely unsustainable over a 30-year period. So we're spending a lot of money, but we have unmet demand still. We have large health disparities, as we know, in this country on the basis of race, ethnicity, as well as socio-demographic differences and regional differences. We have poor outcomes in too many settings. We've got lots of exciting new interventions that fill our conferences, but for example, I'm a breast cancer clinician in triple-negative breast cancer. The median survival for metastatic disease is still a little over 1 year, and certainly it's the same or worse in many other major diseases. And we still are not delivering the interventions that do work to all patients, at least not with any reliability. So lack of access is an ongoing challenge. So it's as simple as this. How do we reduce costs, maintain or improve quality, and meet a growing demand? So some of the solutions, or recognizing the challenges, would be to understand what drives the cost of cancer care. And I think I'm covering here issues that other people have either addressed already in the first two talks or will be delving into in greater detail. But some of the issues or contributing factors are demographics, behavior, novel interventions, both effective and marginally effective, and then overutilization, which has many components in and of itself. But the simple fact in terms of demographics is the problem's only going to grow. As we know, we're not getting any younger or thinner as a country. So for all cancers, the median age is 66. And as you see from this chart showing the demographic trends, the group that's over 65 is going to nearly double or more than double over the next 20 years. And unfortunately, unless something changes again in prevention or early treatment, we're going to see more cases of cancer. Costs will go up. We also, as we know, have had a lot of attention to the obesity epidemic in this country, and it's felt that it may contribute an additional 500,000 unnecessary new cases on the basis of obesity alone. This chart helps us focus the problem by showing those states where more than 30% of the population are obese. So if we just focus on the red states, we can solve the problem. And even if we can address the obesity epidemic, we still won't have addressed the fact that as a country we are aging. So ongoing challenges in this area. And I think ultimately, there's this tendency to want to tackle this at the system level and describe the big costs, and I think that's important. But we're going to need to get granular here, as I think all of us recognize. If we focus just on breast cancer, and you saw some interesting data on this already this morning, the costs over a decade doubled for treatment of early stage breast cancer. This was before the advent of trastuzumab, which is I think we would all agree, a high value intervention that's applicable to about 20% of the population of patients with breast cancer who are HER2 positive, but it comes with a price tag of approximately $50,000 a year. That's really unaffordable. I think the median household income is something around $40,000 in this country. So we know this is not, I'm told it's a little higher, but this is unaffordable for most people. And we've got new data. This is all good stuff from the recent, the plenary address at ASCO, the Amelia trial, where second-line TDM1, it's sort of a trastuzumab chemo conjugate, the latest data is it prolongs survival. Cleopatra, first-line pertuzumab. Pertuzumab has now recently been approved for use with docetaxel. And trastuzumab, where we saw a improvement in progression-free survival by 6 months. And in a subsequent press release following the presentation, we have seen a survival benefit. Or the NeoAlto trial, and this is a little bit more speculative, but if you look at the neoadjuvant setting, adding the drug lapatinib to trastuzumab and chemo essentially doubles the pathologic complete response rate, which is felt to be a good surrogate for long-term outcomes. So all of these drugs may be important, and this may not be a discussion of low-value interventions. These may ultimately prove to be high value. They may actually save lives in the adjuvant setting. But the question is, if that's true, and that clearly needs to be proven by trials that are just now getting started, but if that's true, and we all should hope that it is, what will it cost? If you look at today's figures, lapatinib costs $3,000 a month, pertuzumab is about $6,000 a month, trastuzumab is $4,000 a month, TDM1, if it's approved, will presumably be the same or greater. So that alone would be $13,000 a month, not taking into account infusion costs, the chemotherapy backbone that will likely still be needed. How will we pay for this? We need to balance cost control and innovation. It's been estimated the average cost of a new drug is on upwards of $1 billion. And there's multiple reasons for this. I mean, the problems and challenges of overregulation have often been cited, but even if you could make regulation very streamlined, there's increasingly limited patient populations, both from the standpoint of research. As we have a better and better molecular understanding of cancer, we're dividing our groups into smaller subgroups, which is a great challenge for drug development. And then, of course, the market that people are trying to reach is that much smaller. And when they do have a hit, they feel the need to recoup their large investment in R&D. There's also, for the things that are going to have highest value, the adjuvant setting, where we'll hopefully see more cures, there's a very long time horizon to determine outcomes. So the investment is very uncertain, and there's a great challenge for innovation, particularly if you're going to talk about things like price controls that limit their downstream ability to make up for all the investment early on. And the French National Cancer Institute put together an audit. In France, apparently, cancer costs are about 10% of the total healthcare spending, about double what we see in this country. But cancer is an even greater burden, proportion of that. 30% of deaths, 36% of what they call premature deaths. And the expenses of drugs, where a lot of the focus has been, do we talk about price controls? This is particularly a concern in the UK and France and other countries where there's more of a universal healthcare system than we have so far. But they found that for cancer, actually, proportionate to other chronic diseases, they're spending less on drugs as a percentage of total spending. So maybe there needs to be more investment in drug development rather than critiquing the prices of some of these drugs. When it comes to utilization, we need to recognize the need to divide and conquer as we tackle this. So first of all, following on what Vina said, we really need to differentiate between the cost to society and cost to individual patients. These are discrete and different issues. They're related to the overall challenges of cost, but how we tackle them and the implications of them will be different. And then, when it comes to cost, of course, recognizing that not all are created equal. And we might want to, in one hand, be focused on reducing costs. How do we reduce or eliminate this practice to make the system sustainable and care more affordable? But for another group of interventions, all of us in this room and outside of this room may need to become advocates and say, look, the job here is to find more resources so that we can make this available to everyone. And we really need to wear both hats at the same time as we tackle this problem. So with the Lancet Commission, we said for reducing costs and trying to tackle overutilization, it would be nice if we could get our hands around these buckets where maybe you could take certain interventions, or at least the components of the total spending, and say, well, which are attributable to interventions with no proven benefit. Clearly, we can eliminate that, and our whole focus should be educating patients and clinicians about that, eliminating it, maybe cutting it off at a higher level than the bedside. Marginal benefit may have a different, interventions with a marginal benefit may have a different solution, or things where the benefit is unclear but might be of value in some cases. There's just not enough data yet. That also might be tackled differently. Not desired by patients. Well, maybe how big is that bucket exactly? We can talk about it a little more specifically when it comes to end-of-life care, but I don't think we really have our handle around it on a systems basis. And if we could identify that, maybe we would know how much resources to focus on targeting educational initiatives that might address this. Duplicated tests or services, obviously EMR will help get us out of that. But again, how big is this bucket? And then how often is it the fact that there's an equally effective or cheaper alternative? I would argue that we don't really know. If I take the total healthcare costs and you ask me what % is due to overutilization, I really can't tell you right now. I don't know if others in this room can. And if you then said, well, okay, it's felt to be overutilization, but where are the components here, recognizing that these have different strategies to address them, I think we still have some challenges in this area. How do we define value? This has been covered a bit already, but we recognize that while data from randomized controlled trials is essential, it's not sufficient. It may not always apply to the general population. And so we need better healthcare outcomes databases to identify utilization, effectiveness, and toxicity. And one of the things that was recognized and pointed out in our commission was that the proportional investment by society in terms of providing healthcare versus doing the kind of research that's necessary to rationalize healthcare is minuscule, unfortunately. And then the question will become, who defines value? Is it going to be done at the state level? Is it the doctor, the patient, the doctor-patient together? Is it going to be the insurer, which I think has often been the de facto case in this country so far, which most of us probably do not feel is ideal? Or is it going to be a panel of experts? And some of the examples that have proven more or less controversial, some of them have already been mentioned, bevacizumab for breast cancer, where there was a large benefit in the initial study in progression-free survival. Really, every study that I'm aware of has shown a significant improvement in overall response rate, which can be of benefit in some cases and arguably would be useful to me as a clinician. But trial after trial, large trials, showed no overall survival benefit. and the approval for the drug was ultimately withdrawn on that basis. Also, no quality of life benefit was demonstrated. Erlotinib, which, as we know, was a plenary session at ASCO, and I think had more excitement at that time, but it had a 2-week overall survival benefit in addition to some toxicities. So whether that's clinically useful may depend who you ask on this chart, or even within patients or doctors, there may be differences of opinion. Or Sipuleucel T, where they've met the high bar and got approved 4-month overall survival benefit. We all agree that's the gold standard, but it's a really big challenge because you can't tell who's benefiting. You know it's only a certain percent of the population, but there's no biomarker for response. There's no objective measure of response that's better or worse than any other therapy, and it costs $100,000 per patient. So with this survival benefit, are we saying that we now need to tack on this price tag to everybody with castrate-resistant prostate cancer? So on the health technology assessment front, there have been efforts to address this. I think the best known and arguably the most successful at trying to control costs has been the NICE system in the UK, where they've used an explicit threshold of £30,000 per quality-adjusted life year. That translates into about $50,000. But as many of you may know, they've hit a lot of pushback when it comes to cancer care, and they're in the midst of trying some ways around this. Things like implementing value-based pricing, establishing a special cancer fund, but they're moving back to what NICE was designed to avoid in the beginning, which is variation by region. So a person in one part of the country gets access to a service that they may not get in another. And I think the jury is out on how successful NICE will be over the coming years with new interventions at meeting the demands of the population and the cancer community and controlling costs. In this country, as part of the Accountable Care Act, we've had the proposal for the Independent Advisory Board that as of now is moving forward, but what happens politically remains to be seen. The mandate here is to control costs, but it's explicitly prohibited from rationing, from cuts in services, from implementing cost sharing, from changes in hospital reimbursement. So exactly what tools it has left and how effective these will be, I think remains to be seen. And I was going to try, if we had more time, to pronounce this, the German agency, but I'll skip that. So when it comes to high-value interventions, the question is how can they be most efficiently allocated, and is efficiency really what we're going to go for as a society? Should we be thinking about equitable allocation, and is there a difference, and if so, which is preferable? As I think we know, there's a wide debate on this in this country, and to the extent that we can view healthcare as a commodity or as something special where it's our obligation to provide it to everybody. Unfortunately, that's still quite controversial. When it comes to low-value interventions, where we may say, look, the goal is to stop these and curb overutilization, even when we agree on value, the question is, okay, we want to stop this, but where are we going to do that? Is it going to be at the state level? Are we going to have institution level with formularies and different challenges there? Are we going to let the payers put the brakes on that system, which may or may not be recognized before the cost hits the patient? Or are we going to try to do this at the bedside? If we do it anywhere other than the bedside, how are we going to handle exceptions? Are we going to create, how burdensome is the appeal process? And where's the room for physician discretion, recognizing the complexity of cancer care? So ultimately, it may come down to how do we balance cost control and clinical judgment or clinical freedom? If you allow physician discretion, how are we going to incentivize best care versus lucrative care? That's a challenge we know we face in this country and others. I'll let Dr. Temmel speak more to this issue, but I wanted to simply point out that Medicare spends a lot of money, 12% of the federal budget. A lot of that money is spent in the last year of life, and of that amount, 40% is spent in the last 30 days of life, and I think at least with the retrospective scope, it's ultimately futile care in certainly most cases. So this, if you do this calculation out, this comes to about 2% of the federal budget being spent on people in the last 30 days of their life. It's hard to argue that any of us would feel that that's a sustainable or a good system. And worse, we know that in oncology, studies suggest that many patients never discuss their preferences with their physicians. And when they do discuss them, they often change their mind. They often change the care that they're delivered. Many patients, for example, will say, I don't want fourth-line therapy once I hear that it doesn't work and it comes with significant toxicity, and I could be spending that time with my family and my loved ones. There's nothing else meaningful that you have to offer me in that realm, and we should be focusing on symptom management. Not all patients, but many will choose that. So here, we have a clear opportunity to improve care and reduce costs. And it was with that in mind that ASCO took this on within the Cost of Cancer Care Task Force to say, how can we move towards individualizing care for patients with advanced cancer? Not yet tackling the cases where we're spending a lot of money and the patients want us to do that. That is a challenge in and of itself. But what about when the patient, if we just had a discussion, doesn't want ICU care in the last days of their stage 4 lung cancer? And suggesting issues that can be discussed. Prior to this, ASCO had put out a guidance statement that many of you are familiar with, or some of you were involved with, on the cost of cancer care, arguing that oncologists must recognize that discussion of cost considerations is now an important component of high quality care. So this is novel. Even when I was in medical school, it was sort of around Clinton healthcare reform. We were just starting to talk about this, but I think a generation before, this really wasn't discussed. I think now we're doing a much better job of introducing this as a component of quality care, not just in oncology, but elsewhere. But when surveyed, oncologists agree that this is important. They just don't feel adequately prepared to do it in general. However, having said that physicians should discuss cost of care with their patients, I think we still have some challenges. How and when should they do this? Should we be raising costs at every single visit, touching in with them on this, recognizing that there's multiple competing interests in these 15, 20-minute visits we're having on a routine basis? And what should we be discussing with our patients? What are the goals of these conversations? Are we only talking about the patient's cost, as was mentioned by Veena, or should we be addressing the societal costs? How would patients take that if we come to them and say, well, you're not going to pay anything here, but this is going to be very expensive for society? I think those of us who are clinicians know how that will go over in many cases. What is the impact of this? What are we hoping to get out of this, and how are we going to measure that? And do patients want this? I think we know that there is, I'll leave the cartoon to speak for itself, that there's not yet societal consensus on this issue and on how willing we are to confront the cost of care. We have a society that largely focuses on benefits, not cost. And that was pointed out within the Commission and I think generally echoed in other countries as well as the US. So in summary, we've identified a few challenges. The demographic trends are going to lead to more cases and, by definition, more costs unless something changes. We need to balance innovation and cost control. We need to improve the evidence base to clarify value, and then once we have an improved evidence base, we need to encourage evidence-based practice and figure out how best to do that. In the clinic, we need to balance cost controls and clinical discretion, recognizing that cancer is still a complex disease, and it's sometimes difficult to describe it all with one or even many pathways. We need to engage and educate both the public and clinicians about the importance of this issue and the stakes involved. And then we need to find resources to promote access to care, to high-value care for all patients. And so lastly, and this also came out of the Commission's work, I'd like to argue that we have the emerging challenge, particularly in this country right now, but this country has been the driver of a lot of the science, both in health services and particularly in drug development, sustained in some ways by our high costs here. We need to evaluate cost-controlling interventions and the impact of all the things we're proposing. I think I'm absolutely preaching to the choir on this one. And then we obviously, in addition to spending a lot of money on healthcare, which will be necessary under any scenario, we need to save some resources for ongoing support for basic translational and clinical science, recognizing that we could solve this problem, as Dr. Feinberg noted, by returning to 1970s cancer care for all, and that is obviously not the direction we wish to move. Thank you.
Thank you very much. And now, Dr. Robin Yabaroff, who's an economist, epidemiologist, but I think of you as an economist, from the National Cancer Institute, and she's going to be speaking about the projections on the economic burden of cancer, for which we've heard a lot already, but I think she's going to give us some really good data from NCI's analyses of this.
Good morning. I'm really happy to be here talking about some work we've been doing at the National Cancer Institute projecting the costs associated with cancer care. So I'm going to be talking about temporal cost patterns in cancer patients, the national estimates and projections, some considerations in evaluating cost drivers, challenges in projecting cancer costs, and then finally opportunities for improving cost estimates and projections. So in this first slide, I want to show you, these are temporal patterns of cost of care. So each one of these lines is a cohort of colorectal cancer patients who both lived, were diagnosed with, and died from colorectal cancer. And what you can see is a pretty consistent pattern where monthly costs are very high right after diagnosis and also very high at the end of life. And so this this pattern, which is consistent across these cohorts, is basically a U-shaped curve, with the two arms of the U being the initial period right after diagnosis and the end-of-life period. And then this period down here, period in between the two, is the lowest period. But importantly, in cancer patients compared to those without cancer, costs are still higher in this period. So even in this period where costs are lower, they're still higher than patients without cancer. So a lot of the work we do at NCI is we use that U-shaped curve that I just showed you, and we have a phase of care approach. We take the arms of the U as being the initial and the last year of life phases, and then the bottom of the U would be the continuing phase. And obviously you can do more than these three phases, but these are the three phases we tend to focus on when we're estimating cancer costs, but also when we're trying to project to the future. So these phases can be used with longitudinal cohorts with survival probabilities to model incidence costs, and they can be used with cost-effectiveness models. But they can also be used to model prevalence by phase of care, and then combined to estimate the cost of care in a given year. And that's what I'm going to be talking about. So in some of the recent work we've been doing estimating and projecting national cancer costs, we use dynamic population projections from the census to reflect both the aging and growth of the U.S. population. We use incidence and survival rates projected based on most recently available data from SEER cancer registries. And as others have noted, incidence is mostly declining and survival is mostly improving. We use prevalence, which we estimated and projected by phase of care for each cancer site and gender. And then we use linked SEER Medicare data to estimate net costs of care. So that means the difference between cancer patients and individuals without cancer. And that's also estimated based on recent data. And then we used a couple scenarios for projecting to the future. Our base case was where we assumed that incidence remained constant at the most recent level, survival remained constant, and then cost was also based on the most recent data. And then we made some assumptions about what might happen with costs in the future. And we applied those assumptions to those two arms of the U. So we assumed that costs might increase in the initial and last year of life phases, but remain the same in that continuing care phase. And we also used recent incidence and survival trends. So the assumptions we used were fairly simplistic, but we assumed a 2% increase annually in the cost in the initial and last year of life phases, and that's roughly consistent with what we've been seeing in the first year following diagnosis for the past 10 to 15 years. And then a 5% increase annually in costs in the initial and last year of life phase. So unfortunately, this slide is a little busy, but I want to focus you on, lung cancer, which is right here in men. So these green dots represent observed incidence. If we assume that incidence remains fixed using the most recent year, that's the blue dots. And if we assume that incidence declines over time following that trend, that's the red dots. The main reason I want to show you all these different cancers, though, is to describe their heterogeneity in terms of trends and what we're seeing in terms of incidence over time, and also by gender. So you can see, for example, lung cancer where incidence is declining in men, but not so much in women. So combining all these things, trends and incidence, these are the flat estimates using current estimates. So combining the incidence, survival, and cost, we come up with approximately $125 billion in cancer care, the cost of cancer care in 2010. And you can see that the 5 sites that are the most expensive are breast, colorectal, lymphoma, lung, and prostate, which are also the most common. Now, on this next slide, you can see the percentage of expenditures by phase of care. And so the blue is the initial phase, that left arm of the U where patients are first diagnosed. The red is the continuing care phase, which is the bottom of the U. And the green is the last year of life. And importantly, I just want to draw your attention to breast cancer and also prostate cancer, where even though those 2 red bars represent the bottom of the U, and even though that's a small amount compared to the initial and last year of life phases, because there are so many breast and prostate cancer survivors, those are a large proportion of expenditures compared to something like pancreatic cancer, where survival is short, and you see a very small proportion from the continuing care phase. So if we use population projections to the year 2020, and we keep our incidence, our survival, and our cost of care the same, so the only thing that's changed in these projections is population changes only. It's a 27% increase in the cost of care, from $125 billion to almost $158 billion in the year 2020. Not surprisingly, when you increase the costs in the initial and last year of life phases, it increases to $173 billion. That's a 39% increase from 2010. If you increase by 5% in the initial and last year of life phases, our estimates are a 66% increase from 2010, or $207 billion. So there are a lot of considerations when evaluating some of these simultaneous cost drivers. We've got population changes we've talked about already, incidence trends, and what we've observed may change a bit depending on what happens with obesity in this country. It's been mentioned earlier. Stage distribution at diagnosis is complicated because even though within phase of care, patients diagnosed with later stage disease have higher cost, if you look over a lifetime, their costs may be lower because they don't live as long. So it's a complicated, depending on how long you're projecting or modeling, the changes in stage distribution don't always represent decreases in cost. Survival trends, and then importantly, we've talked about this a little bit already, changes in the use of services. So targeted therapies, imaging, growth factors, hospice, importantly, is changing. It is increasing recently, but it's hard to say how big of an impact that will have in last year of life costs. Also, changes in frequency and or use or unit cost per service is important, as well as hospitalizations, and I'm going to come back to hospitalizations in a minute. So I borrowed this slide from a paper that Peter Bach did in New England Journal of Medicine in 2009, mainly just to focus on the shape of this curve. So you see back in the 60s and 70s, the exponential growth in the cost of new drugs, and that's continuing to this day. But this growth is just really pretty amazing. If you look at different cancer sites, you look at the percentage of Medicare payments in the year following diagnosis by type of service. In this slide, I've got breast, colorectal, lung, and prostate cancer. You see a really big difference based on the types of services that patients are getting. So, for example, if you focus on the purple, which is chemotherapy, in lung cancer, this is a larger proportion of cost than it is in prostate cancer, not surprising. But also in prostate cancer, this blue line here represents other services, those that are not immediately related to cancer care, or not related, sorry, to surgery, chemotherapy, radiation, or other hospitalizations. Importantly, though, the two of the larger categories, cancer-related surgery, which is this top light blue color, and other hospitalizations, which are the red, are a large proportion of the total expenditures in the year following diagnosis. In this slide, I'm showing proportion of net Medicare payments due to hospitalizations in the initial phase of care. And this is by cancer site. And you can see a lot of heterogeneity in terms of proportion, similar to what I showed you in the last slide. For breast cancer, a relatively small proportion, about 25%, compared to things like lung cancer, where the percentage is over 75% of expenditures. This next slide is the proportion of net payments in the end-of-life phase of care, and here things are much more similar, where you see a very high proportion of payments for hospitalizations across cancer sites. Almost all are over 65%. And these are net payments, so this is the difference between cancer patients and those without cancer. So not surprisingly, there are a lot of challenges for estimating and projecting cancer costs. One of our biggest challenges is data completeness. Rarely do we have information across the entire care trajectory from diagnosis to death. One of the exceptions is something that we use a lot at the National Cancer Institute, which is the SEER Medicare data. But those are only mainly for the population aged 65 and older, and they only have complete information for those with fee-for-service coverage. So we have little information by care trajectory, little information for all payers, and this is particularly important for the uninsured population. We have very little information about the types of care uninsured patients get across the care trajectory. We have little information, longitudinal information for patients under the age of 65 outside of managed care environments. And even though we use the SEER Medicare data, and it is a large proportion of the country, it's still not nationally representative. Another big challenge we have is data comparability across different types of data. So there are a lot of differences in patient populations, and sometimes these data are combined without consideration of the population differences. Methods for identifying patients can be important, and the type of data. So are these claims, encounter data, discharge, or survey-based? Those are all challenges. And then, importantly, prevalence changes are relatively slow, but the treatment patterns can change very rapidly, which makes it very complicated to project patterns of care and also costs into the future. So there are also some opportunities for improving cost estimations and projections. Currently, there's a lot of efforts to improve the quality of the data that we can use, such as state-based linkage efforts. There's something called the Medical Expenditure Panel Survey Experiences with Cancer Survivorship Supplement, which has additional information on cancer survivors, and including a special survey that looks at things like financial burden and bankruptcy. Ongoing evaluation of trends, both patterns of care and costs, and also a lot of opportunities for comparative studies. So, for example, within the Cancer Research Network, there's this ongoing study comparing care and costs in managed care setting and also in the fee-for-service setting for the elderly. So it's possible to try and isolate the impact of payment system on costs and outcomes. And then finally, comparisons of patterns in care and costs in other countries. So with that, I'd like to acknowledge my colleagues at the National Cancer Institute, Angela Mariotto, Joan Warren, Martin Brown, and Rocky Foyer. Thank you very much.
And our last speaker for this session is Dr. Zeke Emanuel from the University of Pennsylvania. Where are the healthcare cost savings?
Thank you, Patty. It's a pleasure to be here. And I think my role overall here is to say quite firmly that the enemy is not out there, the enemy's in this room. We are the problem, and I'm going to try to show you why I think that's the case. I like to begin this slide to reemphasize to everyone there are lots of ways of talking about the healthcare costs in the United States. But we will spend this year $2.8 trillion on healthcare. I've gone to just about every group of really smart people in this country and overseas, and one of the things I can be 100% sure of is you have no idea how big that number is. We're very comfortable in this room dealing in millions, hundreds of millions, billions, even tens of billions, but when it gets to the big T, we have no idea. So there are lots of ways of making the comparison to make it come alive. This is my favorite. If you just rank countries by GDP, the United States is by far the largest at $15 trillion in GDP despite the recession. China's number 2, although that number is fuzzy because of what to do about the exchange rate. I would draw your attention to France, the 5th largest economy in the world, $2.8 trillion. France spends $2.8 trillion for everything for 66 million people in France. That great French food, those great French wines, vacations in the Riviera, crappy Peugeot cars, everything, right? In other words, the American healthcare system is the 5th largest economy in the world. All right? 5th largest economy in the world. That seems ridiculous at some deep level. And we are on another planet, as has been mentioned, but I think when you put it on this graph, it really makes it clear. This curve shows you on the x-axis how rich a country is. That's GDP per capita. The y-axis shows you healthcare spending per capita. Those of you who have great eyesight will see the R squared in the top left corner. That's 0.88. Patty will tell you how many times you get an R squared in social science in 0.88, like never. Biological sciences, like never, right? You got to go to chemistry and physics to really see those. That's a very tight curve. And I spend about 40 minutes with my students at Penn discussing all ramifications of the curve, why it's upward sloping, the fact that it doesn't behave like a basic necessity like food or clothing or housing. It behaves more like diamonds and Rolls Royces. That might tell you something about the way we treat healthcare. The fact that as we get richer, we spend a lot more. The important point for us today is the United States is in a different planet. We are not on planet Earth. We are somewhere else. That little gap is about $700 billion per annum if we came down to that curve. That's about 4 or 5 different estimates have come to roughly the same number, somewhere between 600 and 800 billion. There is lots and lots of room to move and to get us to a more rational place. And I like to say, most importantly, there's lots of ways to get us to a more reasonable spend without rationing. I don't think there's anyone in this room who would reasonably say, oh, in Switzerland, they ration care. They're on that graph. We can decrease with our costs without rationing care. I do like to emphasize the fact that spending at these high levels is not benign. I was recently giving a presentation, and the head of a very important hospital system in my neighborhood asked me, well, what's the right spend? And I think it's very important to understand what the consequences of what we are spending are. High costs have real consequences. Medicine is not special in the sense that it has a profound impact on lots and lots of other aspects of society. Our high spending is not benign. It is almost uniformly a negative consequence. Just consider the problem of education. Right? Everyone knows that the cost of education is going up. It's going up much more rapidly in public schools, and the main reason, for example, that tuitions are going up much higher at public colleges and universities has all to do with health care. States have to spend on Medicaid. That goes up. They can either raise taxes to spend for other services or cut other non-healthcare related services. And the biggest part of state budgets is education, prisons, infrastructure improvement, and education gets hit. And higher education in particular gets hit. Here's just one budget director telling you the facts. Medicaid and other healthcare expenses are predicted to grow as much as 40% of the state budget by 2015. That will force the state to cut higher education funding because there are few other options. It certainly seems to be on a collision course. That's Arizona, but I assure you it is not unique to Arizona. And if you worry about the future of this country, presumably education is one of the things you're worried about, and the fact that support for education is declining across the board. Just look at the University of California. Stagnant wages. Over the last 30 years, health insurance premiums have increased 300% after inflation, corporate profits 200% after taxes, and wages have actually, in the private sector, gone down. This is a graph I published some years ago, and this is healthcare inflation year on year in the circles, and this is wage change year on year. And one of the things, this is 30 years worth of data, you can see is that when healthcare inflation is high, wage growth is about 0 or negative. When healthcare costs come down, wages are going up with a slight delay. Healthcare costs come down, wages go up. A couple of years later, when healthcare costs go up again, wages go down. You can think that's just coincidence. It's hardly coincidence, because as healthcare costs go up and employers have to cover those costs in fringe benefits, They keep cash wages down. And finally, there is the fiscal cliff that has been mentioned. The long-term future of this country depends upon what we do in healthcare. Medicare and Medicaid will rise from 4.5% of the economy today, that's of total spending in the whole economy, to 20% by 2050. 1 out of every 5 dollars. Just those. Forget private insurance for the half of American population. Right? That's the central long-term thing. If we don't want to look like Greece, right, we do have to get this under control. At some point, without a whole lot of warning, the international bond market is going to say, we just don't trust you. And then we will look like Greece. So we do need to get costs under control. I think that's undoubtedly true. And yes, we need to improve value, and we need to maintain quality, but we also really need to focus on dollars. Every time I go around talking about this to medical audiences, I get a lot of pushback about us. One of the first 3 questions is inevitably, oh, defensive medicine malpractice, why wasn't malpractice in the Affordable Care Act? Or, my patients are demanding this. Or those nasty insurance companies, Lee Newcomer, right? They're for-profit, just to call out one of them, right? We can go through each one of these, and I'll go through a couple of them to talk about the question of what their real impact is. For sure, there are enough evil people in the healthcare field, but that's not going to save us. And keep pointing out there is not going to save the problem. We, doctors, account for 80% of the spend at least. We have to step up. So let's just talk about medical malpractice for a second. It has, according to the Congressional Budget Office, 0 effect on the growth year on year of healthcare spending. Malpractice premiums and settlements and administrative costs associated with the whole system, about $35 billion. It shouldn't say 2%. That's slightly over 1% of healthcare spend. That's the premium side of things and the settlement side. And the defensive medicine, the best estimates when you look at before and after trends of change in malpractice, about $66 billion or 2.5% of total healthcare spending. Why is it not more, despite doctors' feelings? Because there are many things pushing us to do that extra MRI in the EW or whatever we're doing, right? There is malpractice and maybe defensive medicine, but there's also reimbursement. There's also the way we were trained. There's also what our peers think of us. And just taking away one piece alone will not change our behavior. If you look at the tort reform, the best tort reform that's been evaluated empirically by health economists in terms of its effect on spending, and probably the most draconian change, $250,000 cap on non-economic damages, $500,000 cap on punitive damages, reduction in the statute of limitations to 1 year after the discovery of the malpractice for adults and 3 years for children, replacement of joint and several liability so that you are liable only for the proportion of the harm that you did. If you look at this combination, according to the Congressional Budget Office, they would reduce malpractice premiums about $3.5 billion total. They would reduce defensive medicine about $7 billion, maybe for a total of $11 billion under sort of rosy projections. That's 0.5% of healthcare spend. Let me just suggest to you, that's the equivalent of pencil dust. That's much smaller than the uncertainty of total healthcare spend. It's a real number, and I was very active for malpractice reform, as was the president, but we should be realistic. This is not $50 billion in savings. Insurance company profits, those nasty guys. WellPoint, United, Aetna, Humana, you take the 5 biggest, which dominate the market, you look at their combined profits in 2010, a record year until that time. I think they went up to $12.2 billion in 2011, right? Another drop in the bucket. Whatever they're doing, and those very rich executive salaries, we can decry them all we want, but they're a relatively small drop in the bucket of $2.8 trillion. There's the million-dollar babies problem. We're spending a lot of money on just a few patients, and their patients demand a lot of services. I like to step back and say, yes, patients may demand a lot of services, But why are they demanding those services? There's certainly something cultural in it, but how much are we to blame? Drive down the New Jersey Turnpike, right? Do they get these demands out of nowhere? Right? Advertising cyberknife, MRIs, right? Proton beams, Da Vinci robots. And how many oncologists, how much do we, when we report 2, 3, 4-month advances in survival at ASCO, call that a breakthrough? Every year we have a breakthrough from the plenary sessions at ASCO of a few months. Is this not creating patient-induced demand? It doesn't come from nowhere. And the idea that it's patients driving this and somehow we're not, by the back door, driving patients, I think, again, is meant to mitigate and allow us to sleep easier at night. And there's not a whole lot of evidence of patient-induced demand. Now, it's very salient to us in the clinic when a patient comes in and asks for something, especially asks for something very expensive. I've looked at the literature, and maybe someone will correct me and tell me I'm wrong. I have not seen any evidence how frequent that is, how inappropriate that is, that they're asking for an item, and whether that, in fact, is a high-cost item or not a high-cost item. We just don't know. Now, it's very clear why it's salient to us as doctors practicing, right? But what's salient doesn't mean it's common. So where do we find the real savings? So let me just emphasize this really important point. This, I like to say, is the second most important graph in health policy. The first one was all those countries and the fact that the United States is off it. I want to first, I know we always like to emphasize the big bars. I like to emphasize this small bar here. Half the American population doesn't even participate with the healthcare system. That's obviously an exaggeration, but only slightly. 50% of the population uses 3% of costs. They are out of the system, right? They might break their arm or have a little laceration or get otitis media or strep throat or the flu. But they're our kids. They're young, healthy, or our grandkids. They're young and healthy. They don't interact. 10% of the population is where all the money is, right? We know who those are. Those are people with chronic illnesses, multiple chronic illnesses, and cancer. And that is who we have to focus on if we really want to control costs and improve quality. They're the people who are spending where we're spending the money and that are getting the uneven quality. Now, there has been a long discussion about whether it's the physician's obligation or not to have anything to do with costs. I like to point out that in the AMA, whatever it is, 10 principles, there has always been actually a phrase about the physician's obligation to society. It doesn't end only with the patient. The ACP has been a little more explicit in their latest ethics manual, where they say physicians have a responsibility to practice effective and efficient health care and to use health care resources responsibly. Parsimonious care that utilizes the most efficient means to effectively diagnose a condition and treat a patient respects the needs to use resources wisely. There are many other arguments we could make for this. I think it is undeniable that we have not just an obligation to our country, but an ethical obligation to actually be prudent with the use of resources and not profligate. Let me just emphasize, I think we need to be very rigorous with our own criteria. And this is especially true when we talk about innovations. Right? An innovation has to do one of four things, or it's not a true innovation. It has to improve survival. It has to improve the quality of life. It has to reduce side effects or reduce costs. It can do any one of these four to be a true innovation. Doesn't do one of these four, not proven to do one of these four, it's not a true innovation. It's a false innovation. So we, I would argue, can have a very low entry threshold. I agree with Jeff Peppercorn. We got to look at all of those 6 wedges. But as we all know, getting rid of quote-unquote low-value treatment raises the argument of low value to who, how low is low value, is 2 weeks worth it, etc. We can easily start with no value treatment. Right? What is choosing wisely but arguing zero value there? And I bet if we ask Lowell Schnipper, those 5 things are just not the end of the discussion. So let's just commit ourselves to getting rid of no value treatment, right? No value treatment. No value treatment. And we could go on. All those tumor markers after you've done adjuvant treatment for breast cancer. We know about that. The Da Vinci robot for prostate cancer surgery. Any proof? We're coming up on 1 million surgeries in this country, and you might be surprised that there's not a single randomized trial. And there is some evidence that it's not better in terms of side effects. Certainly, it's unlikely to be better from longevity standpoint. As I say, I think choosing interventions wisely is a good place to start. I've added a couple to the list because I don't have institutional responsibilities the way the ABIM did. And we could go on. I believe we could easily get probably 20, maybe 30 without much sweat. But we can't stop at just the 5 that we have. But I believe that's the place to start. And I think we could make a substantial change in those places, not proven to do one of the 4 things: increase survival, reduce side effects, improve quality of life, or reduce costs. Proven to do those. And I would just remind you of this graph. We can never get too much cost control. There's no such thing in our current healthcare system. $700, $800 billion there. We have a long way to go. Thank you very much.
I'd like to invite the panel to come up here at their seats. And while they're getting to the table, I would like to encourage anyone who has a question or a comment to come to the microphone to start our discussion, which we have here. And again, this is an opportunity for those of you to respond to the things that have been said, or if you have comments, we don't want to have them be lectures, but comments that would be worthwhile. Go ahead, Monica Bertagnoli.
Yes, hi, I'm Monica Bertagnoli. My current job is the head of a clinical trials group that is funded by the National Cancer Institute. So I guess I need to address my question to the panel, but especially Dr. Emanuel. What about the proven and the fact that we spend such a tiny portion of both the NCI budget but also our overall budget on the clinical trials that actually get the data? You know, as a clinician, we are always sitting there with, geez, maybe this works better and we don't have another option. And that drives so much of what we do that has such high economic impact. So I wonder on your thoughts about funding.
Yeah, I couldn't agree with you more. I think the proven is very important, and I've written in a number of different places. First, I do think that I'm a big fan of coverage with evidence development, that we do a sort of conditional approval where we agree to cover something. I don't think we're rigorous enough in the evidence development side of it that, you know, if you're not going to get the data to us by 3 years, we're just going to stop paying for it. I think that would be the right way to go, to provide a very hard and fixed incentive for people to get data and generate. As I mentioned, you know, I think we're coming up on 1 million. Someone will correct me, but it's 1 million surgeries with Da Vinci and not a single randomized trial. I think that's an embarrassment, and I think we do need to establish that we've got to prove it before we're going to cover it long term. So I think that's inevitable or essential. I would also say the flip side, you know, we oncologists tend to be really good at adopting something that's proven, but not stopping to do something that turns out to be unproven. And I will give you my favorite example. I'm sure lots of people can have their favorite example, but it's the single-dose radiation for uncomplicated bone mets. You know, we had a trial, I don't know, 2007, I think, randomized trial. Uptake, as best as I can tell, at major institutions. If it's not zero, it's pretty close to zero. Last time I addressed a radiation oncology department, I got a huge amount of pushback on it. Oh, the patients are all different. You know, the data's the data. You don't like those data, generate other data. But those data suggest it makes hell or beans worth a difference. And, you know, we understand that there's a 3.5-fold reimbursement difference for those, you know, 10 treatments versus 1 treatment. And this is a case actually where for patients, right, the transportation cost, the impingement on their life is so much in favor of 1 treatment as opposed to 10 fractions. So, you know, I think we have to be better about using the data we have.
Dr. Mendelson?
Thanks. John Mendelson from MD Anderson. This is a question, I guess, for Zeke Emanuel, but I'd like help from any of you. There's something I don't understand. Clear data says 18% of our GDP is going to healthcare. Then there's the statement that 10% of America's population accounts for most of these costs, and cancer and some major chronic diseases are big in that group. And then the third piece of data I heard today twice is that cancer care accounts for 5% of healthcare costs. Now, if cancer care is a big deal in this 18% of the GDP, and it accounts for only 5% of healthcare costs, what are healthcare costs? What is that $2.5 trillion? I don't understand it.
Well, we'll just unpack it.
Good.
So, 33% of your healthcare costs go to hospitals. About $830 billion worth go to hospital and hospitalization. I would just emphasize for you, again, put that number in context. It's more than we spend on all of Social Security. It's more than we spend on defense. It's a huge number. All right? It's the biggest single segment of the GDP, as best as I can tell.
Okay,
Okay.
and 30% of hospital admissions or 25% are probably cancer. How can cancer only account for 5% of the total healthcare costs? The numbers don't add up.
I agree. I don't want to say anything about the NCI estimates, but here's what I would suggest to you. As we were told, the NCI estimates have a lot of deficiencies, and you would expect their deficiencies to be in the area of underestimation for a lot of reasons, one of which is most of us have the experience that younger people get a lot more intensive cancer treatment. And they have only over 65 estimates.
We adjusted for under.
Well, right, but you have to make a guess as to how much to adjust, and that may or may not be true among other things. But you can depend on. Let me just say the second big component is doctors and office visits, which is 21% or so, of which half is doctor salary. So doctor salaries account for about 10% of the total health care of the system. And everything else, I like to say, is in the weeds. Just down in the weeds. You know, even drug spending is been 10%, and it's been 10% for forever, you know, decades. And part of that reason is as costs for brand names go way up and specialty go up through the roof, we're using more and more generics. Now, at some point, probably in the next 2 or 3 years, we're going to max out on generics. We're going to be at the 88, 90 percentile, and then the real impact of specialty drugs are going to be felt because I think that proportion going to drugs is going to increase. But everything else, dental care, hospice, home care, all under 10% and in the weeds. That's the breakdown. Now, I would also say the other thing is cancer patients, what, 1 million a year, right? New diagnoses. 500,000 die, so we're treating
Million and a half.
1.6 million.
So we're treating 2 million people a year. That's under 1%, right? That's 0.6%, right? They're getting 10 times the cost, right? If we're 5% of the total spend. Is that clear to everyone?
Yeah.
We represent 0.6% of the population, and we're spending 6% of the total healthcare spend.
We'll
on them.
agree cancer patients are expensive,
Well,
but it's
there's
still only
congestive heart-
5% of the total cost.
Yeah, but there's congestive heart failure, there's diabetes, there's emphysema, there's asthma, there's depression. That's where...
That's the other 95%. The point I'm making is...
No. Not the other 95%.
No?
10% accounts for 65% of the total spend, not 100% of the total spend.
All right. I still think we have to understand the weeds better. People like you that have the training and the data, it doesn't add up to me. There must be something else contributing to the cost of health care besides going to the hospital. And I don't know what the hospitals spend a third of care, if so huge amount of cancer patients in hospitals, and yet they only account for 5% of costs. There's something here that doesn't fit. for me.
Robin, do you want to address this?
Yeah, so I'm going to wade into this one.
I need help, thanks.
Well, I think part of the discrepancy depends on if you're looking at all medical care among cancer patients, or if you're trying to look at the cost of care that's attributable to cancer. So I think there's some difference in there that helps to understand. So what we were presenting are costs that are attributable. We're trying to estimate costs that are attributable to cancer.
What does the $2.5 trillion include attributable costs? Yes. Tell us about that.
Of course it does.
Yes, but it's,
Any interaction with the healthcare system.
right, you're including all costs, not just...
So you're including the costs of the jobs that are lost and the time away from work and...
No.
No?
Direct healthcare costs. Direct healthcare.
Right.
Yeah.
Not the indirect. Yeah.
Not the indirect.
Okay.
Maybe
Thank you.
Dr. Kramer?
Hi, I'm Barry Kramer from the National Cancer Institute. There were two speakers this morning, and especially Zeke Manuel, who likened cost of care to a malignancy in the healthcare system. That being the case, and it's a systemic malignancy, I would say, much like real malignancy. And if so, it has many, many pathways, and each of those pathways has many growth factors that have gone awry. And the one driver pathway that you pointed out was us, physicians or oncologists, who have a certain expectation of income. And in that light, I want to ask a question about the availability of empiric evidence. One of the common strategies that's suggested is capitation. And so the physician is aware that the money will run out on a given type of patient or syndrome, and then can himself or herself move into the red. So my question is about empiric evidence. A physician can respond in one of two major ways. They can basically make more judicious use with every decision all along the way, or they can sort of keep track of when they're going to cross the line and start losing money, not make smart decisions until they reach that cliff, and then basically tell the patient that there's really not much more to offer. Do we have evidence which way physicians are most likely to respond in terms of capitation?
Well, I think the short answer is we don't. And I think the second answer is, you can do these kind of interventions badly, or you can do them well. And I would say that if you looked at the 1990s, in general, as a society, we did them badly, which is we just plopped the cap on. Docs said we're going to pay them capitation. They had no idea how to manage risk. And I think more generally, our experience was they had no idea where the money was going. We assume that we know actually where the money is, but I'd say that most docs in practice have no idea where they're spending the dough, right? They don't know how much is going to chemo, how much is going to the hospitalization, how much is going to adjunctive services, to imaging, etc. So if we're going to do capitation, the first thing we need to do, and I think you'll hear about it from Lee and others, is educate doctors about where are you spending your money. And it turns out we don't all spend it in the same way. We're profligate in many different ways. And you saw that from Scott's slide, which is some people do a PET CT on every patient who comes in and don't, and others, I presume, are wasting money in other places, probably hospitalizations that are unnecessary or growth factors that are unnecessary. And so, I mean, our first step, if we're going to go to the rate of bundling or capitation or some defined limit and not fee for service, is going to be to educate docs where are they spending and where is it unnecessary. I think the second thing is, as was pointed out by Vina, you know, there are real live choices they have about, you know, just the things that, if you're a medical oncologist, chemotherapy, that have cost implications. And probably most of us don't think about that, or are only now just getting into thinking, well, does it make a difference? If there's no difference in survival, we ought to rank this by cost, and that would make a huge difference. And there's a good reason we don't think about it, right? Right now, we're not paid to think about it, and we do make money by not thinking about it, or by doing the most expensive thing. And so we have to get the clinical practice aligned with the business practice. Otherwise, we're not going to get the right behavior. But just aligning them in and of itself without the data and without education and without infrastructure of, you know, guidelines that are designed to sort of standardize care, et cetera, we're not going to get to the right place.
Scott?
Just a quick answer, at least I don't know about capitated payments per episode, but certainly capitated systems, we have some evidence that they do a much better job of not spending money on wasteful care. So you notice in that slide of PET CTs, I didn't identify clinics, and those were clinics. I'll identify one, hopefully because it's a good thing, which is group health was 0 or almost 0 on that scale. They were not ordering in that case. Colony stimulating factor, another slide I have, I thought about showing, I didn't. It's near 0 in group health. I've talked to folks in Geisinger. They were not using Avastin in breast cancer before the FDA took it off the market because they didn't believe the evidence. So there are systems that look at the data, translate to doctors who are usually salaried in those systems, and they all agree not to waste that money.
I'm going to just go to the other side and have newcomer comments.
I only have a couple of clarifications. One, although I did talk about capitation in the 2009 conference, United Healthcare does not capitate any oncologists anywhere, and I think there's been some confusion about that. Just need to clarify. Another clarification for John, in the commercial population at United, 12% of our total budget goes to cancer care, and we can expand on that further too, but just to add another number, that's the commercial segment.
Thanks. Sharon?
Sharon Murphy, scholar here at IOM. I want to point to something that hasn't come up yet in thinking about the total societal burden and individual burden of cancer treatment and affordability. We've talked about acute toxicity and hospitalizations, and yet with increasing numbers of survivors, we cannot ignore long-term late effects of therapy that are adverse. And as somebody who's been a pediatric oncologist all my life and have, you know, we have increasing numbers of survivors, not just among children and adolescents who've been cured of cancer, but breast cancer. And we have to think in making choices and advising patients about the benefits of treatment compared also to the risks of long-term late effects, talking second malignancies, myelodysplasia, heart failure, you know, hip replacements for osteoporosis. And I wonder if anybody, this has not really been measured systematically. I think we know it's a pretty big chunk, and as there are longer and longer survivors, this total trajectory of healthcare costs has to somehow be calculated into the whole equation as well.
That really calls for more data on the long-term late effects and costs associated with those late effects.
Just a quick comment on that. I spend a fair bit of time looking at surveillance of cancer survivors and the costs. And one of the most frustrating, I'm interested to hear what you guys think, is the lack of data on the efficacy of most of the surveillance procedures that we do. And, you know, again, it gets to this issue of costs, of long-term costs. What are we monitoring for? Are we doing something effective to reduce those costs?
Yeah, that's a good point about, I didn't want to address the surveillance issues, which really need more evidence-based, but just the actual events that happen to long-term survivors, which are, you know, they're increasing pool of people and more longer life expectancy and toxic treatments.
spend a lot of money looking for those events. Yeah.
Hi, I'm Ralph Flexel. I'm a radiation oncologist from the University of Chicago, and I enjoyed your CyberKnife and proton slides. But this is for anybody. What are how does one deal with this when we pay doctors to do procedures or order tests? I think the recent PIVOT study shows that radical prostatectomy does no good at early stage prostate cancer, and there's no reason to think that protons or CyberKnife or anything else that's very expensive is going to do any good. Yet I've yet to see a urologist or radiation oncologist turn down a patient. People seem to find a way to want to do this. So it seems to me this needs really a radical overhaul, because the capitation in the 90s worked to some degree, but I think patients have a tendency to get shortchanged. But it seems to me there has to be some fairly strict guidelines, or it's never going to work. But you guys are the experts.
Just in parallel to that, I actually had a comment that's related to this. I mean, healthcare is a major portion of our economy in terms of people's jobs, et cetera, et cetera. And I think as I was hearing the presentations, one of the issues that always comes up is if we do fewer mammograms because the guidelines indicate that they're not indicated in certain populations, or we do fewer surveillance tests, then the bottom line for the hospital and the physicians and everybody else drops down. So any kind of change that we have to make has to be done very, very cautiously because of the ramifications. And I'm certainly advocating for the kinds of changes that have been discussed, but I think the implications to this large economy that also increases the demand, you know, Zeke, all the advertising you saw is because there's a huge medical industrial complex that is out there marketing everything to everyone, including the public. So does anybody have any thoughts about how we make this kind of transition which will lead to better quality value care at lower cost, but not do heroic damage to a large sector of the economy?
Well, let me just say, let's be realistic. There's no one on this panel, and I don't think there's any responsible health policy person saying we're going to take $2.8 trillion and we're going down to $2 trillion. We're not going down, right? The slide that Scott nicely showed is, right, it's the rate of increase is going to slow a little bit. It's still going to be over GDP. So let's be clear. We're not taking the healthcare economy and shrinking it. We're taking the healthcare economy and growing it more slowly. That's what's at issue here. And that means we're not getting rid of jobs, right? We're going to definitely reassign jobs. We're going to be doing different things than we're currently doing. But that's a very different message than we're getting rid of or reducing. The other thing I would say is, or two other points. Scott had a nice slide about if we keep growing healthcare costs, it's actually going to have a negative impact on the GDP over time, right? Healthcare costs are not, again, just to emphasize, they're not benign. Yes, they keep employment for the moment, but they have a very negative externality on the rest of the society. And the last point I would make, if you actually controlled healthcare costs, we actually shrunk healthcare costs, right? That money doesn't disappear. It doesn't go into the ether, right? What would happen if we actually reduced healthcare costs, right? Real wages would go up. Economists tell you this. People would actually get paid more. And amazingly, most of them would spend that money generating economic activity. It wouldn't be at the hospital. It might be at the mall, might be at restaurants, might be at cultural events, might be on vacations. But the economy would hum along, and it probably would hum along better because of the slide Scott put up. We are not, healthcare is not necessarily that productive a segment of American society. Remember, right? Spend $100,000 prolonging someone for 4 months. How productive is that?
But again, to get to the point, this is not how the individual practitioner looks at it. The individual practitioner's got to make a living, right? I mean,
Ralph, you're absolutely right. We can talk till we're blue in the face, and certainly many august leaders of our profession have talked till they're blue in the face about the responsibility to be prudent, etc. We don't change how we pay docs, right? We're just hot air. I think it's that simple. We have to change how we pay docs, and we're not going to do it overnight because it's a $2.8 billion ship. You don't change the fifth largest economy overnight. It's going to slowly change. So I think that's going to change. And I think there's, you go around the country, there's tons of activity about how looking at shared savings, looking at bundles, looking at capitation. We don't know the best method yet, but we're going to change.
And we're going to hear some of that
Very
in the
good.
sessions later on. Yes.
Thank you. Walter Ettinger, I'm the Chief Medical Officer at Accretive Health. I wanted to ask a question about price and prices, both price within a region. And, Dr. Ramsey, I liked your slide that showed a 5-fold difference in the cost of treating breast cancer. How much of that was due to differences in price? And then, Zeke, how much of an issue is price when we compare other countries? So when you look at that gap on your graph, what does price contribute to that as opposed to utilization?
I'll answer so just to go back to that graph, that was a graph showing quartiles of spending for stage 1 breast cancer over 12 months, lowest to highest. Lowest about 20,000, highest about 120,000. Those are all commercial plans in our region, the 4 biggest. I purposely removed Medicare and Medicaid because their prices are much, much lower. Bottom line is the prices are very similar for all of those plans. I wouldn't say price was a big factor.
So let's make 3 points. The first is we know price for the same thing varies tremendously in a given geographic region. A relatively small geographic region can be 400% or 500%. And so there is a important role for price variation. On the Europe U.S. Comparison, or not just Europe, but developed countries, price is a substantial amount of that difference. But prices and volume are not two factors which move separately. Remember, if you've got something which is a high price and there's a high margin to it for the physician community, turns out we also do end up doing a lot of it. So if you just look at sort of straight comparisons, we have about twice as many knee replacements as Europe does. Let me guess, our price for knee replacements is high compared to Europe. We have about 1.5 times as many catheterizations and stent placements and cabbages. We have about, I think, 2 times as many C-sections in the United States. Cardiologists got into C-sections, I think, all those Cs, lots of doing them. So price and volume aren't separately correlated. And, we know this in oncology. You got a high price for something, the office makes a lot of money, or you have to get your RVU quantity up. We end up doing a lot of those things. We have the second highest number of MRI scanners, I believe, in the world, and second highest number of MRIs per person. We have the most CT scans. Margins are good. And, up till now, radiology has been a revenue center. And, we'll see those numbers change when it becomes a cost center. And I think there is a relationship between price and volume, and we have to get price under control.
Is there anything we should be doing actively to do that? You talked a lot about the panel.
We've made 2 proposals a couple of weeks ago in the New England Journal that directly address this price issue. One is we need more competitive bidding on things that are commodities and can be competitively bid. The federal government's gingerly getting into that. In the Affordable Care Act, we included having competitive bidding for durable medical equipment, prosthetics, orthotics. In the first year, that brought prices down 42%, suggesting that price setting by Medicare wasn't all that accurate. But it's due to expand by 2016 to the country, but we could accelerate that expansion, which we've urged. I also think we can expand it well beyond the durable medical equipment. It's not clear laboratory medicine isn't that kind of commodity, and you can't just sort of begin having competitive bidding on laboratory tests. Maybe putting someone in an MRI or a CT scan looks like a commodity at some point. And, we could think about the things where we could do competitive bidding. The second is, most people think we need some pricing transparency out there for items or groups of items, and that pricing transparency with quality metrics. They can't go separately because how do you know whether the price is related to quality? And we need to have those. We have a lot of, unfortunately, places where we have gag clauses in contracts that don't allow the revelation of pricing. I think the pricing imperative, as I like to call it, is inevitable in the next, I don't know, 3, 4, 5 years. We are going to have full price transparency because I think it's hard to have people make purchases. Individuals have co-pays and make purchases and make decisions about where to go without pricing transparency.
Thank you.
Thank you.
Yes. Good morning. I'm Douglas Peterson from the University of Connecticut Health Center, and I'd appreciate some context from the panel, perhaps Drs. Peppercorn and Ramsey, if I may. For many years, I've been working in the area of evidence-based supportive care guidelines in cancer, and that most recently was discussed in an education session that we had at ASCO this past June on mucosal injury in cancer. And we're in turn now in discussion, early discussion with the Clinical Practice Guidelines Committee of ASCO to really propel the evidence-based supportive care piece within ASCO. And then in turn, I'll be chairing a new Gordon Research Conference next June on mucosal injury in cancer, where I'd like to integrate some of the best of this into that science as well. And so my question is, in the context, and I'm a newcomer to the economics of this, what's the degree of connectivity, say, with ASCO or NCCN guidelines for cancer treatment in relation to economic outcomes?
It's an evolving area. I can speak. I've been on the ASCO Clinical Practice Guidelines Committee, and I can just say that I think now there's an active effort to move towards including at least transparency with regard to costs into the guidelines, if not making decisions exclusively based on cost. So that's clearly where things are going, but I can say that there was a lot of discussion, took a long time, Lowell knows, to even get to that point. But that's recognition that has to happen. So I think if you're starting out now in the supportive care world, clearly trying to integrate that up front would be smart.
Vina and I wrote an editorial in the NCCN guidelines. That's where the data that she showed came from, showing that vast difference in the cost. NCCN has no opinion about which one a doctor should choose. I'd be curious which ones they choose most often. I don't know. Do we have data on that?
I don't think we have data on first line, which are the most commonly prescribed first line gastric cancer regimens, but I would imagine it's the oxaliplatin-containing regimens that tend to be a little bit better tolerated and tend to be more expensive.
So the bottom line is we actually looked at that for a number of different, NCCN guidelines and found similar huge differences. So, right now NCCN doesn't have a policy on thinking about costs, and it certainly wasn't, that data is not in their guidelines. As you're thinking about supportive care, I think it behooves you, if you believe in the spirit of this, to look at those costs and look at the efficacy in the simplest terms, like we just showed, and report that for patients and physicians.
And you might even think about the charge that Zeke gave us, because if supportive care reduces toxicity and side effects, that's a benefit, obviously. So the cost might be offset by that.
Right, and in part ties, and it was one of the earlier questions on the late effects as well. So, so I appreciate the context. I think I have some homework after this meeting. So, thanks.
Dr. Piantadosi.
Thank you, Steve Piantadosi, Cedars-Sinai. I'd like to get the panel to address an issue that they haven't touched on yet, and that has to do with the fading of private practice oncology in the United States. I'm not sure if people are aware that 80% of cancer care is delivered in the private community, and that private practice oncologists, in fact, are not able to pay their own salaries. That means that their revenues and the solvency of their practices comes from downstream chemotherapy revenue, ancillaries like RAD-ONC and the like. And in fact, if I were looking for explanations of some of the data I saw this morning, it would be who owns what, and that'll tell you what services they ask for their patients. But in addition to this force at work on private practice, we're under-training oncologists right now. The current estimates, I think, in the coming years is that
we may be undertraining by as many as 100,000 specialists. So I wonder what impact this will have, if any, on what needs to be done and the economics that we've been discussing for the next few years.
I think there's probably people in the room who know more about the workforce issues than I do, but I think that we're going to have to challenge what the ideal workforce is. For example, in breast cancer, where I practice, a lot of physicians, some of my colleagues, their practice may be 80% people coming back for their survivorship visits. And increasingly we're finding that with, as people have demonstrated a long time ago in Canada, where you can be transitioned to your primary care physician with no difference, at least in some of the major outcomes we worry about, we can certainly, within a cancer center, transition them to mid-level care. We're looking at ways to get internists and others involved, which I think, within the cancer context, where maybe we can deliver something a little bit different. So I guess I would be a little bit agnostic on what the real workforce issues are. Although certainly I think you could argue that we're not training people well for the challenges they're going to face in the future.
Let's note something. I do think it's true that the sort of income expectations and where doctors generate income come from, in oncology, from doing stuff and not the office visit and the cognitive side of things. If you change the payment structure, and that leads, just hypothesize for a second, you give a bundle to the docs to manage, the medical oncologist, or you give a capitated payment or some other arrangement, reductions in other services that may be either unnecessary or we could have prevented. So unnecessary PET CTs, or we could have prevented a hospitalization. That money stays in the pool. And doctors would actually retain those resources. And the ratios are such, again, if you just think that doctors are now about, their salaries are about 10% of the total spend of healthcare. If you reduce hospitalization rates, say 10%, that's a 3% total change. That's a 30% change in physician salaries. So small changes in other places can actually redound to doctors' benefit when you've changed off of fee-for-service. And I think that's how we're going to have these changes, right? Almost everyone in this room, I think, would agree getting rid of those PET CTs for stage 1 breast cancer patients with no 0 or 1 comorbidities. Did I get that right? No effect. 0, right? That's 0 value treatment. Okay? There's that, under a bundle payment, saving that money goes into the doctor's pocket, or at least the bundle payment pocket. And so I think you can see how the economics could change pretty substantially for better care and actually better reimbursement for doctors. So we got to get off the old thinking that the more we do, the more we're making, and rethink how we're going to make with different payment models.
Dr. Wenger?
Hi, Neil Wenger, a primary care doc at UCLA, and I direct the ethics center there. Primary care docs aren't always great at discussing costs, but we do it. Yet we're hampered by not being able to address the patient who says, gee, doc, I don't know whether to go to the proton place down the road or to get the tomograms that your radiation oncologist here have recommended, or the urologic procedure, or on and on. Yet, if this conversation were occurring at a primary care meeting, it would all be about how can we as primary care docs do a better job of stewarding these resources. Yet, until Dr. Emanuel talked, there was barely a whisper of that at all. I guess my question is, where's the responsibility of the professional organizations and the institutions in which they reside to call for stewardship and to think about societal costs?
Well, look, these things don't change overnight, but I do think, we're having this meeting for a reason, and that reason is all about cost. The Choosing Wisely campaign was all about that. the change in the ACP guidelines to use words like parsimonious and efficient. I think there's a sea change here, and I would say it's a pretty irreversible sea change in the medical profession. It may not be fast enough for you, Neil, but most of us, you like me, are pretty impatient. But I do think it's changing. And so I'm actually, in general, quite optimistic. And I actually think by the end of the decade, 2020, 10 years after passage of the Affordable Care Act, what happens and how we treat our patients and the kind of discussions we have with our patients is going to be very, very different. We are going to have that cost discussion probably as a matter of routine. That would be my prediction.
Dr. Schnipper.
Just to insert, because that's an excellent question. I'm Lowell Schnipper. There's a lot of my colleagues from ASCO here who have worked together on the task force on the cost of cancer care. And I would say that since 2007, when ASCO established the task force, the central thesis has been, what can the physician do to drive the cost curve downward? Which is not to say that we've yet been successful, but we have done quite a lot, and I'll amplify that when I speak this afternoon, quite a lot at trying to raise levels of awareness both in the patient community and in the specialty community, and make a very important assumption, and that is, within the context of a healthcare system we cannot yet control system-wide, there's an awful lot that the physician can and must do to be a responsible steward of the patient's resources and society's resources.
Thank you. Dr. Schrag?
Hi, I'm Dr. Schrag from Boston on Dr. Schnipper's task force. So my question has to do with, so as part of healthcare reform, obviously there's an enormous movement towards accountability. But if you look over the last 15 years, oncologists have come to control or own, if you will, less and less of the patient experience, and some other physicians have grown up in their stead. So I'm thinking particularly about our wonderful colleagues who are palliative care physicians, and also about our colleagues who are hospitalists, particularly my senior colleagues. I see a lot of you guys in the back row. They did it all. They had no hospitalists. They rounded on everybody. And even I'm old enough. We know palliative care is great, but we did it all, right? We did all of it. And so we didn't need to coordinate with 4 other services. So I guess in terms of trying to be efficient, do you think that this, sector-specific, these handoffs are going to help us deal with our economic crises? Or do you think that we need to foster accountability? We need to go back to a more, I'm going to put my arms around you and I'm going to take you, if you will, cradle to grave with this cancer experience. So it just seems to me there's a real tension there, and I don't know what your thoughts are.
I think less as any kind of policy expert than as a clinician, I can reflect on that. That every time I get involved in the patient, when they're in the hospital, for example, where I do have colleagues, in this case not hospitalists, but I rotate, sometimes it's me, sometimes it's a colleague. When I get involved and make the time to go there, it invariably changes the course of care. And I think both that and in the clinic, something we haven't really talked about, and I think, look, you don't have time to talk about these things. That's always a poor excuse. We have the time. But as Zeke alluded to, we're not reimbursed for that. If it changed so that 80% of your income was based on having a great discussion with the patients, people would feel really well informed, and I bet we'd see large drops in what was done. And you see this in medical training, where the residents and house staff don't have time to think. They got to get them in and out the door, and it's easier to just order that test, order that scan, find out immediately before you think through and see what happens. So I think you've hit on one of the major challenges here. And I don't think we're moving back from the subspecialization. I think the palliative care docs contribute something invariably, and I'd like to see that grow. But I also think you have to do that without taking away the responsibility from the oncologist.
Go. Well, I guess my response is that if you're talking about sort of the fragmentation of care among multiple specialists, I'm not sure. This is probably an open question, and if people have data on this, let me know. But to me, that doesn't immediately suggest higher cost care. It again gets back to Zeke's point of how do you pay those people that you're fragmenting out to. If you're paying them to do more stuff, they're going to do more stuff, whether it's one physician coordinating it or many. Is there inefficiency in the transfer of one to the other? Possibly. I don't remember any data on hospitalists in terms of increasing the cost of care, if there's people who have that information just in general, not in oncology. please feel free to disagree. But it gets, to me, the question isn't who's taking care, it's what's their incentives and how are they getting reimbursed. Are they getting reimbursed for doing stuff? Or are they getting reimbursed for patients having better quality of life, lower costs, et cetera?
So I would say that we are in an inevitable trajectory towards more team-based care, and we are not going to be the jack of all trades, the triple threat, or whatever phrase you want to use. So I think the idea of going back to where your and my mentors practice just ain't happening. The question is, do we have team-based care that's organized efficiently, or do we have it organized inefficiently? And if you look at the best systems, not in oncology, but at the best systems in other areas that have actually reduced costs for patients with multiple chronic illnesses and a lot of complications, almost all of them have very good team-based care where they can put the right person with the right training on it. They have people who subspecialize or super specialize. So for diabetics, it's one person who does wound care and only does wound care or manages Coumadin or whatever. But they also have instruments like shared medical record with very clear care plans delineated to make sure that everyone's on the same treatment page, and that if, God forbid, the person goes to the wrong, calls the wrong bell, they have a palliative problem, but they end up calling the medical oncologist, that everyone knows what the right plan is, know who's responsible, and can shunt them. I think just because of the explosion of knowledge, the explosion of interventions, there is no way we're going back to the jack of all trades approach. That itself is inefficient because we learn, very early, either in residency or very soon thereafter, what we do. Our habits don't change as much, and we can't keep up with all that literature. So I think it's an inevitable team-based system, and the question is efficient or inefficient teams.
Jim?
Jim Heyman. I'm a radiation oncologist from the University of Michigan. I was curious about the panel's thoughts in terms of what area along the continuum of care might be the most prudent to focus on first. So I was struck by the data from the National Cancer Institute suggesting that at the end of life or the last year of life, the costs seemed to be the same regardless of what cancer you had, or pretty close to the same, whereas there was much more variability in treatment and in surveillance depending upon the type of cancer. And so that made me think a little bit, and also this issue about really marginal benefit. Maybe that the end of life or the last year of life might be an efficient area to focus in on first. But I'd be curious to hear what other people might have to think about that.
I guess you have experience with that.
Yeah.
The first thing...
Mostly cutting people off.
Yeah. The graph that we showed was the proportion of costs at the end of life phase that were due to hospitalization. So the payments themselves at the end of life are fairly different by cancer site, but it varies a lot by hospitalization. So cancers where there's a lot of hospitalization tend to be more costly than those with less hospitalization. But your point is well taken. There are a lot of similarities across all cancers at the end of life that you don't necessarily see right after diagnosis or also during a more surveillance period.
I wish it were different, Jim, but I don't think there's an expert in end-of-life care who can get up today and say definitively, we know how to improve quality of care at the end of life and save money. We've been working on this area for, a little less than 25 years, probably conscientiously, and mostly what we've had are failures on the cost-saving side. So I think, I have my favorites interventions, but I can't tell you, I'll bet a nickel or I'll bet $1, I'll bet my favorite thing at dinner that, this is really going to save healthcare costs. We don't know the answer to that. We know there's wide variation hospital to hospital, there's wide variation among patients, but we can't definitively tell you what that is. I don't think that suggests we shouldn't try in that area. But we do, you know, again, my urging would be, we know places where we're doing tons of zero value, where it's proven to be zero value, or there's no proof that it's of any value, and there's good reason it's not going to be of value. And we should focus our initial efforts on that, because no one can justify that, it seems to me.
And do you think that happens more frequently, you know, during initial treatment, during surveillance?
Well, I think you've got, I think a lot of it is in the initial treatment and then in the surveillance period. I mean, look, I don't know. Correct me if I'm wrong, Deb, but when I was training at the Farber and we finished a woman on adjuvant chemotherapy for breast, she came in the first year every 3 months, and then every 6 months. And then where did that come from? And then, and by the way, we ordered the whole panel, right? You know, CBC, LFTs, all those tumor markers, you know, et cetera, et cetera. Where did it come from? All right? I think there's a lot there that we could easily get rid of. That's no evidence. There's good evidence it's not actually beneficial.
Thanks.
Tom?
Well, I came up to say something different. My name is Tom Smith. I'm a medical oncologist, but also a hospice and palliative medicine specialist. And in fact, there are fairly good data showing from randomized clinical trials showing that better coordinated end-of-life care integrated into regular cancer care and regular medical care reduces the costs. Kaiser Permanente did 2 randomized clinical trials. About a third of the patients had cancer, 2/3 didn't. But in each one of those, identifying people in the outpatient setting who had less than 2 years to live and identifying sick inpatients, and then randomizing them to usual medical care versus usual medical care plus an interdisciplinary palliative care team, it saved Kaiser Permanente $4,800 to $7,000 per person, even including the cost of the palliative care team. And I've had discussions with Kaiser over the past year or so, and that has become the standard of care in every Kaiser market. And in fact, I haven't found a single study in which palliative care added to added to usual care actually increased costs. The real reason I came up the microphone was in the interest of full transparency. I am a medical oncologist, and the data about medical oncology salaries is a little bit hard to come by, but the best and usual source has been the Medical Group Management Association, the MGMA. And although we like to complain, the MGMA 2011 figure for the median salary of medical oncologists was $407,000, twice as much as most cognitive-based internists like primary care, gerontology, et cetera. And that's actually gone up higher than other specialties in the same time. So perhaps there are multiple explanations for that, people falling out because they couldn't pay their own salaries, but the data that we have, the data on which we traditionally relied, shows that medical oncology salaries continue to go up rather than down, and we need to readjust that. Thanks.
I'm so glad you said
Hi.
that, Tom. I have that data too, but I held back.
Harvey?
I'm Harvey Cohen. I direct the Center for Study of Aging at Duke University. I'm geriatrician and medical oncologist, and I head the Cancer in the Elderly Committee for the Alliance Cooperative Trials Group. I want to get the panel's thoughts on a little different driver, potentially, and that is, it's been pointed out that 30% or so of costs are hospital-related costs, and increasingly, or at least fairly broadly, many large health systems are where chemotherapy costs, et cetera, reside, rather than necessarily in the physician's hands. I mean, physicians may drive it, but the costs and the dollars are flowing through these health systems. So I was curious about your thoughts about the health system as a driver and approaches to the health system in terms of ameliorating these costs.
All right. I think again, here the inevitable answer is if you end up changing how you pay them, so we don't pay a margin for going to a health system, a big margin for going to a health system, or you give them a bundled payment, they are going to manage patients differently. That's inevitable. So I know that a lot of health systems, I mean, one of the reasons they're buying up physician practices or buying up smaller community hospitals is they're basically anticipating moving care from the center to the periphery where the overhead is less and the cost at which they can do business is less. And I think that's going to be a trend that you're going to see more of. And the reason they're doing it is they do have the capital in which to, do it. But I think that shift, again, is in response to their anticipation of where the payment system and structure is going.
But if the health system, for example, makes a larger portion of money from the prescribing of an expensive rather than a non-expensive drug, physicians report to those folks, and they're going to say, yeah, I guess I'll do that because that's what the boss wants. So it seems to me we need some part of the drivers here to be addressing those issues as well as the physician, who surely we bear plenty of culpability, but I think there's another driver at play as well.
If you take those things either out of the payment or that they don't make more money for it because you've got a bundle or a capitation, they will see the light.
Lee, we'll take just the last few people at the microphones and then take our break.
Fiona, I don't want you to feel neglected. So a couple questions. One, you talked about bankruptcies induced by cancer therapy, and I think the Kaiser Foundation also looked at medical bankruptcies. But what struck me about the study was the average amount triggering a bankruptcy was, I believe, $10,000. And so I need to verify that. But if that's the case, should we not be considering that? Is it reasonable to expect an American family, this is above the safety net, of course, to accumulate more than $10,000 in savings over as they approach their retirement years? Second, my other question is, should we then, given that circumstance that there isn't any money for out-of-pocket expenses, should we not pay at all for Zeke's non-value therapy? Should a patient be expected to take the whole bill for that, and therefore have the discussion about value if they have no money?
So as far as the bankruptcy data is, sorry, that was actually, if you could maybe, I could ask you to comment on the trigger point for the bankruptcy, because I was actually not directly involved in that data. And then I can answer your next question.
So that bankruptcy data we presented at ASCO in 2011, and one of the biggest factors influencing bankruptcy was the age of the patient at diagnosis. And younger patients had much, much higher rates of bankruptcy when they were diagnosed with cancer. So sure, when you're hopefully saving as you get older, and you might have noticed that we had over 65 as a cutoff, and the difference between the population and the general population and cancer patients was lower, still higher, but it was less of a difference. A lot of workforce America just doesn't have $10,000, and particularly the younger you go. I don't think that it's going to be an easy solution to have people save more to avoid bankruptcy in those cases. I'll turn it over to Veena for the part two of that question.
I think a lot of the spending that we get concerned about, that there's a lot of out-of-pocket payments for, and what you referenced are treatments towards the end of life, treatments that have questionable value. Most of the time when patients get to that point, they've already spent a large amount of their savings on treatment. And so I think it's hard to expect that patients would be able to pay for those treatments if it's something they wanted. So I think the decision has to be, is there value in treatment? Can we universally recommend a particular treatment to all patients? And if patients are financially in trouble, does that decision then sway whether they would be willing to pursue that treatment or not?
Hi, my name is John Sprandio. I'm a community-based medical oncologist outside of Philadelphia. I just want to make a couple of comments. My practice was recognized by the NCQA as a medical home about 2.5 years ago. And I wanted to echo a couple of comments from our experience that really echo the comments from this morning, in that if clinicians, physicians, providers really take full responsibility for addressing the failures of care delivery, care coordination, and overtreatment in oncology, the significant resources can be saved. And that's where it all begins. That's really the foundation of this. I think we're in a very interesting transitional time period. I think it's going to be exciting, and there's lots of different models. Lee is with the episode of care payment model, and Peter Bach's going to be talking tomorrow as well. But I think it'll be a very interesting couple of years in really redefining the methods of care, delivery of care.
Thank you for giving us.
How much did you save? Don't get away without telling us your experience.
We can talk about it more
dollars.
tomorrow morning, but basically we were able to reduce internally within our practice our ER utilization rate by 68% over a 4-year period. We were able to reduce admissions by 51%, again, for patients who are receiving chemotherapy over a 3-year period. The dollar figure is substantial. And we're in the process of is expanding this and getting some real data from more than just one practice.
Thanks for giving us some optimism.
Last comment. Larissa Nicoleta of Harvard Medical School and Harvard Vanguard Medical Associates. So just two quick points. Number one, Dr. Feinberg made a comment about insurance should be seen as a sort of a shared effort. And I think here too, I think patient education, although other pieces really do need to be emphasized, I think there is definitely a role for patient education, because as a primary care provider, it's not uncommon for patients to come to me saying, well, I have health insurance, I pay for health insurance, I can get this MRI, so can you please order it? The other piece is, you know, even though I practice in a really, I think, well-functioning integrated healthcare delivery system, often my patients will say, well, I don't really want to go to the docs in this integrated healthcare delivery system. I want to go to the best docs, and I happen to be in Boston. So I want to go to the best docs that are available because I have health insurance. And so I think that we kind of need to reframe our patients' expectations about the healthcare system and make sure that patients understand that, you know, just because they have coverage doesn't necessarily mean that they should be seeing different docs all over the place. And that's particularly the case for Medicare patients that I see. They just go wherever they want to go. We just implemented the Medicare ACO, so we'll see kind of where that goes. But that was just a quick point.
Thanks very much. So this has been really an outstanding session. Thank you for getting us off to a great start today for our panel and our participants in the audience. I think we'll take a break until 11:20 when we're going to have a keynote address from Dr. Mark McClellan. Please take a break.